Hello, welcome to X-Ray Matters, the podcast where we explore why X-ray really matters in healthcare today. I'm Ryan, your host, and I'm excited to kick off our very first episode. Joining us today is Dr. Joanna Start, a consultant thoracic radiologist at Leeds teaching hospitals in the UK. Joanna works at one of the busiest departments in the country, where chest X-rays are performed every single day to support cancer care, emergencies, and much more. Leading today's conversation is Professor Matthias Goyen, Chief Medical Officer at GE Healthcare. Matthias is a radiologist himself and a global voice in imaging and innovation, so he's the perfect person to guide this discussion. Together, they'll dive into the role of X-ray in lung cancer diagnosis and how Leeds is improving the patient pathway and the exciting new technologies being introduced to help clinicians and patients alike. Let's jump in.
Joanna, it's a great pleasure to have you on the show. Welcome to the podcast.
Thank you.
So let me ask you, let's begin with the first question we ask all our guests. Why does X-ray matter to you?
I think X-ray is a great test. We use it as the first line test in the investigation of lung cancer for patients with specific symptoms. And the patient experience, you have to always think of the patient, and it's a quick, readily available test in Leeds. They can walk in and have a chest X-ray done. So I think it's a great test as an initial test.
You mentioned Leeds. That's the site where you work. Leeds Teaching Hospitals NHS Trust is one of the largest in the UK, serving over 1.5 million patients annually, including 200,000 emergency cases. That's an incredible amount of cases. Can you tell us a little more about your place where you work and what it really means to handle such an amount of patients?
Yeah, like you said, it's a very busy trust. It's a fantastic trust. It's a specialist centre, so both a tertiary and quaternary centre for certain subspecialties. We have a very large cancer centre. We also have a regional centre for interstitial lung disease and cystic fibrosis. The actual hospital itself is split across multiple sites. We have a large hospital at the St James's site and a slightly smaller but still very busy site in the city centre. And we have multiple X-ray departments across as well. So over five X-ray departments at the infirmary.
So you recently became a consultant thoracic radiologist in the department that performs 370,000 X-rays a year. Let me repeat that, 370,000 X-rays a year, 150,000 of which are chest X-rays. Why did you choose to specialize in chest radiology? There are so many beautiful anatomical areas. Why the chest?
That's a very good question. I think it's a really exciting field at the moment. We know that lung cancer remains a really big problem in England and internationally as well. I think there is really exciting developments such as the advent of lung cancer screening in the UK, and also the different pathologies in the chest, the different abnormalities are so vast that it's a really exciting field. It's something I've just chosen through training, really.
So let me ask you, how is your department organized to manage such a high volume of patients? If you could just talk a little bit about that.
Yeah, so so already we have a number of X-ray departments. So at the LGI site we have the 5 X-ray departments, and we have X-ray departments also across the St James's site and geographically dispersed so that it manages the services for different patients. We have an X-ray department that's very close to the cancer centre or within the cancer centre, and an X-ray department also right next to accident and emergency. And that's quite a large majority, obviously, of our work as well, with inpatient work. We have many radiographers, and a lot of them are X-ray radiographers, and they do a fantastic job at managing the workload. Yeah. We also have to remember that every patient should have a report for their chest X-ray as well. So we have reporting radiographers who also do an excellent job at keeping on top of their reports.
Right. So, Joanna, you mentioned lung cancer, and obviously lung cancer is one of the most commonly diagnosed conditions using X-ray. Can you give us an overview of the Leeds Center and how it integrates with the diagnostic imaging services?
Yeah, so in terms of the pathway, there's a number of pathways into diagnosis for lung cancer in Leeds. And most of our patients are patients that present with symptoms, and by that I mean breathlessness, chest pain, maybe cough. And those patients will get a chest X-ray as their first test, as per our national guidelines. And so that's how they enter the pathway, most of these patients. If there's an abnormality on the chest X-ray, we then problem solve maybe with advanced techniques in X-ray, or they go straight to CT.
Right.
There are other pathways as well, such as, you might incidentally find lung cancer on a CT scan, or incidentally on an X-ray of an inpatient.
Can you talk a little bit about the statistics of lung cancer in the UK?
Yeah, so it's the third commonest cancer in the UK. It's also the most common cause of cancer death, unfortunately. So 1 in 5 cancer deaths are due to lung cancer. So it's a real area of need that we need to try and problem solve and move forward with pathways to earlier diagnosis, and really encourage patients to be seeking help initially for symptoms that may feel vague to them, but that are important and should be investigated.
Speaking of lung cancers, are the early symptoms usually easy to detect, or very unfortunately you see patients only when it's really in advanced stages?
Yeah, it's difficult to say, and some patients may present with symptoms quite early on, but a lot of patients only develop symptoms later on in the disease. So it's difficult, but yeah, in England in 2018, about half of diagnosis of lung cancer was made at late stage, and that shows us that actually people are not developing symptoms until late stage and then seeking help and getting their chest X-ray.
So, Joanna, you mentioned pathways. What does the standard diagnostic pathway for lung cancer look like at Leeds? So, if you just could take us on a patient journey. Patient, probably went to their GP, doesn't feel well, is coughing, and comes to you. What happens?
Yeah, so the National Institute of Health and Care Excellence recommends chest X-ray as the initial test for investigation of lung cancer. So, a patient would either be referred by their GP for a chest X-ray, or in Leeds we also have a self-request chest X-ray service for those aged over 40 with 3 weeks of symptoms, chest symptoms, and they can walk in and access a chest X-ray without a referral. So the chest X-ray is that first test. It will then get looked at by a radiologist or a reporting radiographer, and they will recommend then a further test if that test is abnormal, and write back to the GP with instructions. Now, the chest X-rays that are significantly abnormal and look very suspicious for lung cancer, we would automatically recall them via an electronic pathway for a CT scan. And when we use that electronic alert code, that flags it to the relevant lung cancer team. So they're already then enveloped by the lung cancer service, and that's a pathway to try and streamline the diagnostic pathway. They will then have a clinical appointment in the hospital in the fast track clinic with a respiratory doctor who will assess them and recommend anything further. And we also have specialist multidisciplinary team meetings to involve oncologists, radiologists, pathologists, the clinical team, so the respiratory team as well, and other teams that may need to input for treatment, for example, thoracic surgeons.
So if your colleagues or you spot anything abnormal on a normal chest X-ray exam, do they automatically all go to CT, or is there any other imaging modality that could be, following the traditional chest X-ray exam?
Yeah, so the ones that are highly suspicious for lung cancer, we do go straight to CT. But there are many cases where the findings are indeterminate, and I would classify those findings that sometimes you see something, a very subtle or doubtful abnormality, and you think, oh, this is probably benign and not relating to cancer, but I think we need to do a further test to make sure. Or it's something where we need to localize exactly where the abnormality is, and we think it's probably not cancer. In those cases, we may use advanced techniques with X-ray, such as dual energy chest X-ray, and we do quite a lot of that in Leeds. or digital tomosynthesis, and we're starting to do that lots more for these patients.
Okay, so you mentioned two new imaging modalities, dual energy and digital tomosynthesis. Let's start with the dual energy exam. Can you share, with the audience, what is this and what are the advantages? And again, you said if it's not clear that it's really very highly suspicious that it's a tumor, you don't go for CT, but you probably, in between do this kind of technique, the dual energy exam. What is it?
So the dual energy chest X-ray is something we've been doing probably since about 2008 when we first installed our machine. We now have two machines at the trust, one on each main site, the infirmary and St James's Hospital. And the technique is similar for the patient experience. It's very similar to a standard chest X-ray in that you would go into the X-ray room and position yourself exactly the same for a standard chest X-ray, and the radiographer would talk the patient through the process. The technique itself creates three images, and it's a standard chest X-ray, and then what I would call a bone selective image and a soft tissue selective image. And the way this is performed is using two different energies, so it's a high and a low energy, and it creates an image where we can subtract kind of distracting structures out of the way. So, for example, if I see a subtle opacity that I think might be due to a rib or due to a refracture or something like that, we can use the soft tissue selective image to take away the bones and to see, is that truly in the lung or is that in the bone? And if it's present on the bone selective image but not the soft tissue selective image, we can be fairly sure that's in the bone. And we can reassure the patient that actually they don't have a lung nodule or an early lung cancer.
Oh, that really makes sense. It gives you a higher confidence of diagnosis. So this is dual energy, and then you mentioned digital tomosynthesis or DTS. What is that, and in which cases do you go for a DTS exam instead of a dual energy exam after probably a normal chest X-ray exam?
Yeah, so there are two ways we might use digital tomosynthesis in the chest. And the main way we currently use that in Leeds is for individuals who may not be referred on a lung cancer pathway, but they might have quite non-specific symptoms. And what I mean by that is weight loss, loss of appetite, general feeling of tiredness or fatigue or sweating at night. And these patients can be referred from their GP to the non-specific symptoms pathway, where they're seen by a medical doctor. They're examined, a history is taken, and they will do certain blood tests, but they will also recommend this digital tomosynthesis chest X-ray. And the other patients we could use that technique on is if we are wondering exactly where an abnormality is in the chest. So a good example might be something that looks maybe a bit like a nodule, but around the blood vessels that are around the heart. And the digital tomosynthesis allows you to kind of scroll back and forth from the front of the chest to the back of the chest and then back to the front and see where that abnormality lies towards the front or the back. And if it's elongated and looks like a blood vessel, again, we can be fairly sure that's a blood vessel, and the patient can be reassured if their symptoms are not persistent.
So, Joanna, can you quickly explain how such a digital tomosynthesis exam works from a patient's perspective? Do you need to be afraid to undergo the exam?
No, not at all. The process is fairly similar in a way, in that the patient would go into the X-ray room and the radiographer would explain the procedure to them. The difference is the breath hold technique is longer. So for a standard or a dual energy chest X-ray, you would hold your breath for it's a couple of seconds, a few seconds. But the digital tomosynthesis requires a longer exposure, and it's 11 seconds. So these patients should be able to hold their breath for 11 seconds.
Wow. 11 seconds can be very long. That means you really have to see what kind of patients are actually suited to undergo that exam. If you don't have these breath holding capabilities from a patient's perspective, CT would be the next line of examination, and you cannot undergo the DTS exam then?
Depending on what the chest X-ray abnormality is, or if we're using it as a problem-solving tool. There are other ways you can use digital tomosynthesis, and there are machines with tables where you can lie down rather than stand up for the chest X-ray. And some individuals find it easier to hold their breath when lying down. rather than standing, especially maybe slightly more elderly or frail patients who struggle to stand. So it's not you can't just we can still do it, as long as the patient is okay to hold their breath, maybe lying down.
Right. Who decides after you've done a normal chest X-ray exam, what's the next imaging exam? Do you consult the clinicians? Is it the radiologist or the reading radiographer who actually decides it on their own? How does it work? And the second question would be, how has these new techniques have been adopted and also accepted by your clinical colleagues?
We work very closely. The radiology department works very closely with our respiratory physicians, and there's we have a good level of trust and communication across those departments. So, to come back to your first question, the decision doesn't necessarily lie with anyone in particular, but I would say that if I was reporting a chest X-ray examination and the findings are highly suspicious for lung cancer, I think it does the responsibility lies with me to make sure that patient has a timely second test to confirm or to move that pathway forward. So I would suggest that decision at that time lies to me, and that's where that use of that alert code to expedite the process comes in, and that's something that with a click of a button we can recall that patient to move the pathway forward. And your second question, just remind me.
Like the adoption of this technique, when you introduced, like dual energy and DTS into your clinical services, it's something new also for the clinicians because they are so used to the CT. Now, all of a sudden, you tell them, hey, look, we don't do a CT. We do a DTS or dual energy exam. And so my question would be, are there some probably old school clinicians who say, go away with all these new techniques. I want to have my CT. That's where I really see what the pathology is. Or have they adopted it easily?
I think it varies team by team, and I think the level of communication is very good in that there is a trust in radiology that we will recommend the right test, and that we will consult the clinicians where appropriate and whether the patient is appropriate for certain tests. I see your point about digital tomosynthesis being it's a slightly newer concept for the clinicians. We obviously have used it in different ways in radiology for a long time, but like you said, I think clinicians are maybe not used to looking at their own digital tomosynthesis studies or the actual images, and they're much more used to looking at a standard chest X-ray or a CT examination. And I think because we are using it for problem solving as well, and if we are confident that the abnormality is, benign or we need a further test, then the trust in us for that, I think, is good. Yeah.
So, Joanna, you mentioned that the patient deserves a timely next imaging test after something has been found or there is a highly suspicious lesion. From a timing perspective, isn't it probably easier to do a DTS exam, although you only have two machines, I learned, versus scheduling the patient for the CT exam? I'm just thinking, if I put myself into a patient, I really want to have the confidence that I have something either, or luckily it's a benign lesion. So this waiting time can be very cumbersome and also psychologically very, very hard. Does this play a role for choosing the next imaging test as well? Maybe do a DTS the next day versus waiting for a CT exam a couple of weeks?
I see what you mean. I think I echo your point. I think there's a lot of anxiety that that comes with having an abnormal test flagged. The GP may have got in contact with the patient to say your test is abnormal, or the radiographer might have said, actually, the test is abnormal and you need a second test. And I can imagine as a patient that would be, really anxiety provoking. The timings for the different tests they vary depending on the indication for the test. So if we are recalling the patient for a CT for cancer, the timings tend to be days rather than weeks. But I completely agree in terms of if the abnormality is indeterminate and we have the patient in the department, it would be feasible and very reasonable to do a digital tomosynthesis at that stage. And then if it's completely normal, we can put that abnormality down to a blood vessel, for example, or a rib fracture. That's very reassuring for the patient, and that is an ideal outcome. So that is a decision-making process, and a patient can go away reassured.
Yeah. So as a clinician or also a patient, I could argue, I don't need the DTS. Let's do the CT directly after the chest X-ray, because then I get the definitive answer. What do you say to those opinions?
Yeah, I can understand that point of view. I think that for certain abnormalities that on the chest X-ray, they often tend to be smaller, very subtle abnormalities. And we can be fairly sure we're using the dual energy and digital tomosynthesis. So we have maybe up to about 5% of dual energy results, for example, that may need to go on to have a CT to make the decision and problem solve. But actually, dual energy is a very good test to confirm that something is definitely benign or not cancer.
That would have been my next question, but it's great to hear it's only 5% where the DTS results are not clear. So you have to go a third exam, which is then the CT exam. Is it only 5%? This is great.
Yeah, this is from an internal audit that we've done several years ago. There will be it will depend on the type of reporter. If you have a consultant chest radiologist or a specific chest reporter, they may be more likely to make a definitive decision on that result compared to a more junior reporter, for example. But yeah, roughly 5% are indeterminate on the dual energy, and we have to proceed to CT. But I think that's a very good statistic. It's very reassuring that we are confirming these things to be benign. We know that from a standard chest X-ray, if the area of abnormality is overlapping a rib when we look at it, it's got a very good chance of being a benign or an artifactual abnormality, that actually we can do that dual energy and just make sure that it is definitely not cancer or not a lung nodule, and then
So looking into the crystal ball, do you think that in the future these techniques like dual energy DTS will even increase, not only at Leeds, but in general, because it is a great imaging modality that probably comes prior to doing a CT. It's cheaper, it's in general convenient for the patient, and it gives you a clear answer in 95% of the cases.
Yeah, I think especially the digital tomosynthesis, it's a very good test. It's very sensitive at picking up lung nodules. So it's got a higher sensitivity than a standard chest X-ray for picking up lung nodules. So I think there is a population that we need to serve with the digital tomosynthesis, maybe as the first test, rather than a standard chest X-ray. And we are already doing that for those patients who have non-specific symptoms and are on that specific pathway. But there are individuals who are at greater risk of lung cancer, and by that I mean older patients, maybe with a history of smoking, maybe with other conditions that increase their risk of cancer. And using a better test initially probably serves these populations better than doing a standard chest X-ray, whereby the sensitivity is greater with the tomosynthesis.
Right. We haven't talked about radiation exposure. Could you just give a little overview of dual energy DTS, what kind of radiation is emitted versus the normal chest X-ray or a normal standard low dose CT of them?
Yeah, so we usually quote internally for a standard CT of the chest about 2 millisieverts, and for a standard chest X-ray, that's less than 0.1 millisieverts. So we're moving higher in terms of the radiation dose from a standard chest X-ray to a CT. Dual energy is a marginally higher dose than a standard chest X-ray, and digital tomosynthesis again is marginally higher again, but much less than a CT scan. So in terms of dose, you're much better off having the lower dose tests, for example, at digital tomo.
You mentioned lung cancer screening earlier, and I think lung cancer screening programs are now being introduced in the healthcare system. We hear a lot about it, and can you share what's the current situation in the UK, and where do you see things heading with regard to lung cancer screening?
Yeah, the lung cancer screening, the advent of lung cancer screening is really exciting. It's a great it's a great outcome of certain trials, and we had the Yorkshire lung screening trial, which demonstrated a real survival benefit for these patients having lung cancers picked up very early. So most of the lung cancers picked up in the trials were at stage 1 or 2, so very early lung cancers and very treatable lung cancers. And compare that to the statistic I mentioned earlier, in that several years ago, about half of lung cancers were diagnosed at very late stage. So we're moving with lung cancer screening, we're moving to earlier stage diagnosis. These are for the patients that fit that criteria. So their eligibility will be assessed, and they will be invited for screening. But there will obviously be patients with lung cancer that fall outside those criteria, and that will still present with symptoms and they will still get a chest X-ray as a first-line test. So it's a great program, and it's being rolled out probably next year nationally, next summer-ish, I would say. Certainly in Leeds, I think that's our aim timeline-wise. But there will still be a role for chest X-ray, definitely.
Right. Coming back to the educational aspect and thinking of radiology residents and registrars now with these new techniques coming in, dual energy, DTS, how have you integrated this into your curriculum, for radiology residency at Leeds? Can you just talk a little bit about that?
Yeah, we have quite a busy training environment in Leeds, and that's multi-professional. There's trainee radiographers coming through, we have trainee resident radiologists coming through, and these individuals get very early exposure to chest X-ray, to standard chest X-ray, from the first few weeks really. And part of the teaching program is that we will introduce the concept of dual energy chest X-ray very early, primarily as a problem-solving tool, but also for the the evaluation of vascular lines and things like that. So it's introduced very early on, and their hope is that these the resident radiologists become more comfortable with these applications because we are using them in practice. I think that digital tomosynthesis is an area that people will become comfortable with using over time, because at the moment we are the chest reporters and the consultant radiologists will be reporting those tests. But the aim is to make sure that the resident radiologists are trained up in reporting those.
Right.
So yeah, in the local curriculum, we do introduce these techniques and concepts.
Yeah. So, Joanna, we haven't talked about AI yet. Everyone talks about AI in healthcare. It's more than a hype. It's really happening. It's science, not science fiction. It's science fact. When you think of X-ray, where do you see the role of AI helping the radiologist with either the enormous workload or in decision making? Where do you see, what is the role of AI in X-ray?
I think traditionally, at least the general consensus that I feel people think about is that AI is helping us to detect subtle abnormalities that as humans we make errors and we may miss. And there are certainly reported cases that we see subtle lung nodules that are picked up by AI and maybe missed by radiologists. But we are using it currently in Leeds for standard chest X-rays. It's a very maybe slightly oversensitive at the moment and picking up rib fractures and things that we may need to then do those dual energy or digital tomosynthesis to characterize it and rule out opacities as lung cancers. But I think the other application is kind of triaging of reporting. It's a very busy centre that we work in, and there are lots of chest X-rays waiting to be reported, and we are aiming to get to those as quickly as possible. And at the moment, they are triaged by referral priority, so urgent chest X-rays will be reported first, and more routine chest X-rays will be reported after that. But I think if the AI can screen those chest X-rays and say, okay, well, that one's got a pneumothorax or a lung with an air leak, for example, and kind of bump it up the list, I think that would be a quite a nice application of artificial
I,
intelligence.
I think that's every radiologist's dream. Don't show me the normals, but we both know it's far from being trivial, right? So what is normal in medicine? So don't you see the danger if you have AI read a scan first that there are false negatives, for example?
Yeah, and that's why I think training and continued reporting of standard chest X-rays and advanced techniques are so important. We make sure that our resident radiologists and trainee reporting radiographers are reporting tests, looking at the image first, kind of as a blinded test, and making sure that we aren't heavily reliant on the artificial intelligence, as we need to make sure that we are able to weigh up the abnormality on the art that the AI has flagged to us.
Right.
Is we can often say, oh, actually, that's okay. It's not a lung cancer. That's just a blood vessel. So it's making sure that we keep our skill sets high.
So Joanna, it's great to hear that at Leeds, ideally the residents look at the image first when it comes to chest X-ray, and then get the AI as an invisible friend to see if they are on the right track. But couldn't they just secretly press the button first and have a suggestion by AI and then look at it? I mean, the thing is, I'm asking, how do we ensure that our future radiologists don't lose the ability to report on cases? Because I mean, AI is there, just have to click and AI does the job.
Yeah, that's right. And I think it's important to ensure that there is functionality in the AI software, whichever software that you choose, to fully turn that function off so that the radiologists are blinded to the AI. And can't turn it on themselves. So the trainee, at least the resident radiologists in Leeds, are supervised in their reporting, their chest X-ray reporting, early on. And I think they will be sending them through to a more senior reporter, whether that's a reporting radiographer or a radiologist. And so we need to make sure that we can turn that function off. They can report it as they would have done 5 years ago, for example, and are maintaining that kind of high quality training of just looking at the pictures and making a clinical judgment basically based on what you know and looking, using your eyes, basically.
Yeah. So, Joanna, finally, what's your vision for the future of radiology in the age of AI? I mean, will we all be out of business in the future because AI will take over? I mean, we are both biased being radiologists. Where do you see the specialty of radiology in the age of AI in the future?
Yeah, it's a really exciting time because I don't think anyone knows specifically how the next 10, 20 years will look, but certainly the rate of progress is quick and it's exponential. I think we have to embrace AI. It's already here. People say, oh, it's coming, but it's already here. We already actively are using artificial intelligence for measurements of lung nodules and assessing how they're progressing or if they're progressing. So we should be encouraging people to embrace it, but also teaching people how to evaluate its use and to kind of almost critically appraise it and make sure that we're using the right software and feeding back when things aren't going quite right, and feeding back when things are going well as well. So we're using the software correctly and for the in the best interest of the patient.
Joanna, I have a final question for you. Very often in lung cancer, symptoms present only very late, and that is a real challenge. So if I put myself into a patient's shoes, let's say I'm a smoker and I have cough that doesn't go away, what should I do?
That's a good question. It may be that actually the symptoms are related, sometimes they're unrelated, but I think it's really important that patients remember, individuals remember, they should seek help from their GP. And these symptoms matter. Don't dismiss this as it's just my smoker's cough, or it's just something that I know someone else has had and it resolved. You should seek help, and you should prioritize your own health. Just go and see your GP and ask, can I have a chest X-ray? Do I need a chest X-ray? And the GP may direct you straight to the hospital, or they may give you some advice and ask you to come back later on. we are very lucky in our centre in Leeds that we have a self-request chest X-ray service. Okay, the patient can go straight, without needing to see a GP, can go straight to the hospital if they're over 40 years old and have had 3 weeks of chest symptoms, and that's cough, chest pain, breathlessness, maybe tiredness or a lump in the neck. And especially if you've coughed up blood, you should definitely see a doctor. Okay, so an access to a chest X-ray is really important when you have these symptoms. So do see your doctor.
Joanna, thank you so much for sharing your insights with us today. It's been a pleasure having you on X-Ray Matters.
Thank you. Thanks for having me.
Okay, that's it for our first episode of X-Ray Matters. A big thank you to Dr. Joanna Start for sharing her experience on lung cancer pathways at Leeds. And of course to Professor Matthias Goyen for guiding the conversation. We heard how X-ray underpins both diagnosis and follow-up in lung cancer, and got a real glimpse into the exciting role of technologies like dual energy and tomosynthesis, which are helping radiologists see more and make faster, more confident decisions. If you enjoyed today's episode, be sure to follow us on Spotify, Apple Podcasts, or wherever you may listen, and share it with your colleagues. We'll be back soon with more stories from around the world on why X-ray matters. Thanks for listening, and until next time.